right, welcome and thank you for attending Brain on Fire, connecting the dots of infections to neuroinflammation and the neuroautoimmune cascade. My name is Adair Anderson, and I am a clinical lab educator here at Vibrant, and I will be your moderator this evening. Vibrant staff and I will respond to your questions throughout the presentation, and there will be approximately 15 minutes for a live Q&A following the presentation. As a reminder, all attendees are in listen-only mode, so please submit your questions through virtual Q&A. The content of this webinar is for educational and informational purposes only. The information is not intended to treat, cure, or prevent any condition or disease. If you desire medical advice, diagnosis, or treatment, please consult with a medical professional or healthcare provider. And now let me introduce to you today's speaker, Dr. Kim Bruno, who is a clinical lab educator here at Vibrant. Dr. Kim Bruno received her doctorate in chiropractic medicine from National University of Health Sciences in Chicago and successfully completed the Certified Clinical Nutritionist Board examination. She continued her postgraduate education through the Institute for Functional Medicine, the Clinical Nutrition Certification Board, and Lyme Master courses. Dr. Bruno has dedicated her career to working to find the root cause to patients' medical issues, as well as promoting a prevention model of healthcare. Prior to coming to Vibrant, she owned a private practice and worked collaboratively with multidisciplinary practices. Most recently, she was a functional medicine director at the largest immunology clinic in Colorado and specialized in complex care of patients with multiple chronic immune conditions, developing immune rehabilitation plans for optimal health. Dr. Bruno is a Colorado native who enjoys hiking, skiing, and paddleboarding and finds most joy in spending time outside in nature with her husband and her 2 young daughters. Without further ado, I'll turn it over to you, Dr. Bruno.
Thank you so much, Adair, for that great welcome. And thank you everyone for joining us today. Today we are going to be talking about 2 of my favorite tests. And we are going to be really working with those 2 tests to connect the dots with infections and what's happening in the brain from an autoimmune perspective and an inflammatory perspective. So let's go ahead and get started. So the first test that we are going to talk about tonight is the NeuroZoomer Plus. And the NeuroZoomer Plus is an array of neurological proteins and some viral antigens. It's going to measure the antibody response that's related to neurological inflammation and autoimmunity. As always, please remember we're a CAP and CLIA certified laboratory, and we are going to be able to utilize the technology pillar of peptide level antibody detection. And if you would like any more information on that, there is a white paper available in the portal that you can look at. As far as the NeuroZoomer Plus, some of the questions that we get are, is this diagnostic? It is not. These markers are not diagnostic except for one. The antiglial fibrillary acidic protein is not found outside of the brain unless there has been a rupture, a breach of the blood-brain barrier. So other than that marker of the other analytes that are on this test, we are not looking for diagnostic. But so what does that mean? How can we utilize this for our patients? Well, what I like to say is that we're looking at this spectrum of neuroautoimmune conditions, okay? So more so than this end stage diagnosis, because we're not looking to quote unquote diagnose Alzheimer's disease or diagnose Parkinson's, what we are doing is we are looking to figure out where on the spectrum this patient is. So more looking at their symptom presentation, something like cognitive decline, memory loss, word finding issues, because though if we can get to those conditions or part of that cascade prior to the patient getting a dementia diagnosis or Alzheimer's diagnosis, that is a huge win for us as providers. So when I'm talking to patients, I give them the analogy of a train. And I say, when I look at these markers, I know it's at the end of the track. It also gives me clues to how you got on the train. And what my job is as a provider is to try and slow down the train and hopefully pivot the train onto a different track so that we don't ever get to that end diagnosis. So although I will see patients who will come in who already have a diagnosis of MS or Alzheimer's or Parkinson's, and this test still has some utility of telling us maybe some mechanism of what got onto the train, the real utility is going to be in when we're dealing with some of these other types of symptomatology where before they get to the diagnosis. A great doc back east, I heard him say, we would like to get to it before it gets to the patient. That's Dr. Turnpaw. So if he's listening, I'm going to shout out to you because that is a great saying that as a provider to our patients, we want to get to it before it gets to the patient. So let's get to it before it becomes a diagnosis. Okay. So think about your practice. You probably have a lot of patients who have these types of issues. I know that I do. And so this is a test that we really want to figure out, okay, what is the mechanism, right? Is it that they have an infection or is it that they have blood sugar issues or some other reason? And that's what this test will help you to do. So putting it another way, it helps to really give you these like directional puzzle pieces. They're potential predictors that help you connect the dots. Why is that important? Well, so many of these neurological autoimmune conditions are multi-system disorders, and they don't necessarily have a single laboratory test or a single pathological or radiological feature that gives you this standard, this slam dunk diagnosis. So knowing some of these analytes ahead of time and putting that together with our patients' presentation, we get these potential predictors to be able to help them have efficient care, to help them correct course. That's that train ideas. We're going to try and get them onto a different track, okay? So when we're looking at the neural zoomer, there's a lot of markers. There's 47 different analytes. My biggest recommendation is don't miss the forest for the trees, okay? Don't get so caught up and looking and saying, what's going on with anti-MA, or what's going on with anti-dopamine, or what's happening with anti-alpha-synuclein. Although there's some of these that may have some direct molecular mimicry, more look at them in their categories. So Vibrant has put all of these markers into particular categories like brain inflammation, brain autoimmunity. So you already know where you need to start working. And it also helps you to not be overwhelmed, to be able to give the patient an accurate report of findings and something that's not fear-based. Because a lot of times, patients are going to see something like anti-amyloid beta. Well, they've heard about amyloid plaquing before, and all of a sudden they're going to say, oh my gosh, you're telling me I have Alzheimer's. No. I am telling you that we have an autoimmune process that's happening in the brain. And again, I'm going to tell you why you got on the train, which direction your train is going, and how we can help to correct course. So it helps you as a provider to not be overwhelmed. It also helps the patient to not react to this test in a fear base. So looking at these analytes as categories is going to be really important. So we have the category of brain inflammation, brain autoimmunity. That's where we're going to spend a lot of our time today as it relates to infections. There's a lot of other types of nuances, and maybe we can do that in a different webinar. But for right now, we're going to really pay attention to these. These are other analytes. We've got stuff about blood-brain barrier disruption, peripheral neuropathy, the optical and autonomic nervous system, demyelinating, neuromuscular, and the infections. So those together make all of the different analytes that we would look at on the Neural Zoomer Plus. Now, how do we utilize this test? And I hear that from providers a lot when I'm consulting, especially if it's maybe their first one, or maybe I've done a Lyme test and I recommend a NeuralZoomer Plus, and they say, okay, but what am I supposed to do with it when it comes back? Or, it has a lot of just really fear-driven information. So what I like to do, and if anyone's ever consulted with me, I always like to take these tests and figure out, like, how am I going to apply this in practice? Like, what does it mean to the provider? What does it mean to the patient? And how do we make a plan? So that's what we're going to do today. And this is the little hierarchy that I am going to present to you, okay? So we are going to identify those patterns based on their categories. And that's going to help us to figure out what is the underlying mechanism of either their neuroautoimmune cascade, neuroinflammation, and that's going to help us give some action items for treatment. So you want to identify their triggers and their known molecular mimicry associations, deal with their blood-brain barrier, because these 3 action items down here is really what's driving here and here. So when you have a marker of maybe brain autoimmunity, you don't necessarily need to jump in and just like laser focus on the brain autoimmunity. The brain autoimmunity is at the top of the pyramid. It's there because of all of this stuff underneath. So just like you wouldn't start building the house from the roof down, you need to start from the foundation up. So that's where we're going to start today. So the first thing, what is molecular mimicry? Well, molecular mimicry is the process where sequence similarities between foreign antigens and self-antigens are going to cause this auto-activation leading to autoimmunity, okay? So basically things look similar, whether it is a food or an infectious agent, and the body confuses it with self. All right. So in nature, we see this all the time. I put this little picture of this lizard in here that's making itself look like a leaf, right? So we often have this different type of mimicry that can happen. Now, because it's a Wednesday afternoon, it's a week before the holidays, I thought we all needed a little bit of some comic relief. All right. So if you haven't ever paid attention or gone to the website Creative Med Doses, please do. They always have some really fun little cartoons there. So there's their website there. So this is the dilemma of the antibody, right? So you have this antibody here that he's like not sure what to do. He's like, wait a second, you have pink antigens and you have pink antigens. Okay, what should I do? Okay, maybe I should go ahead and kill them both, right? And so now he's doing here, your antibody says, well, I don't want to take any chances. So I'm going to go after both of them. It's thinking it's doing the right thing because it wants to protect you, but in actuality, what's happening is it's going to be causing the sequela of problems. All right. So hopefully this was a little bit of comic relief for everybody on this Wednesday evening. So what do we know about molecular mimicry and the NeuralZoomer? You don't need to memorize all of this. We do have a consideration guide in your provider portal. And if there is a molecular mimicry that we know about, it is going to be in there. You can also schedule a clinical consultation, and us on the clinical team can help you really dive into that to know if there's other things you should be looking for. Because of this level of molecular mimicry with different markers, that's why we often say that, that the NeuralZoomer is best used within a cluster of testing so that we can say, okay, is it infections or is it food or is it toxins or is it something else? So as you can see, if we're looking at antitubulin, this is going to be associated with like heavy metals, especially with mercury. It has an association with thyroid levels, particularly autoimmune thyroiditis. It's got some anti-strep with pandas and some Lyme connection. So if you had a test and you only did the NeuralZoomer and you had an antitubulin come up, you might want to say, okay, I need to maybe look for a Tickborne test here. Maybe I should test their heavy metals. What's going on? Do I have an accurate thyroid test or a more recent thyroid test where I've tested their antibodies? I need to make sure I put that together because that could be some of the driving factors to the demyelination that might be happening for this patient. Okay, so I have 2 slides in here. When you go back and watch the webinar, you can look at these, but you don't have to feverishly be writing everything down, because like I said, these are in the neural zoomer consideration guide. So you can see what are the molecular mimicries of the things that we know about. So think about our pyramid. We want to know, first off, if I see a marker, is it associated with something that I could easily take them off dairy, take them off gluten? I could easily check them for, heavy metals and try and start to work on that. Here's just some other information about some of the other markers that we know about. And I'm going to show you a bunch of different studies for the ones that are related to Lyme, because that's the combo that we are paying attention to today. So the step 2, so we've noticed that we know that there's some molecular mimicry. That's like when we see things that have the molecular mimicry, we're like, easy, great, action item. Okay, remove gluten, remove dairy. Then we want to heal. Step 2 is heal the blood-brain barrier, because autoantibodies can interfere with neurological transmission if they're able to cross the barrier, okay? In a healthy person who has an intact blood-brain barrier, the brain sits at a seat of privilege where the immune system cannot see it. But if that is broken for a variety of different reasons, whether it's a traumatic brain injury, whether it's because of certain foods that they're eating, whether it's because of a leaky gut, leaky brain, variety of different reasons can then cause these autoantibodies to then interfere in the neurological tissue, because they can get there and the immune system can now see the brain, and it sets off this whole autoimmune sequela. So that becomes a big problem. So that's why dealing with the blood-brain barrier, along with dealing with the base of your pyramid, is really where all of the power lies for this test. So how do you heal the blood-brain barrier? Well, this presentation is not necessarily on what are all of those treatment options. Although I think that would be an amazing webinar to have, because we could spend all 45 minutes talking about how do you heal the blood-brain barrier. I'm going to give you a couple of the items that I want you to consider that maybe you haven't thought of before, right? We hear a lot about gut, permeable gut and a permeable brain, or leaky gut, leaky brain. So a lot of us know heal the gut, right? Another thing that you really want to pay attention to is restorative sleep, EMF exposure, vagus nerve, nutrient-dense diet to really help to give those molecules to build up that barrier. And also, if there's something specific, some sort of specific molecular mimicry that's against the barrier, and you're going to see that in our case study, you're going to want to remove that. The two kind of closer looks that I wanted to do tonight is one was on EMFs. We're getting more and more research that EMFs are affecting the blood-brain barrier. So if you have healed the gut and you're still seeing someone and somebody's sleeping well and you think that you've done everything, you really need to address what's happening with their electromagnetic field radiation and so you need to be able to know what are they coming in contact with. Okay, so if they are constantly wearing earbuds, or they're in an area where they're getting a lot of EMF exposure, you could be kind of eating Oreos and brushing your teeth at the same time as far as healing the blood-brain barrier goes, and not making a whole heck of a lot of progress. So make sure that you look at that. Also, the blood-brain barrier, you need to address the vagus nerve. Now, there's different things that you can do as a provider. You can do action items such as deep breathing and exercise, massage, music, gargling. This book, The Assessing the Healing Power of the Vagus Nerve by Stanley Rosenberg, is one of my favorites. I actually ask patients to get it. They have some self-help exercises in the back. It takes them 5 to 7 minutes to do each day to help them really reset. I have noticed that this is also a big barrier, if you would say, that even if we can work on healing the gut, if we can't get this gut-brain connection through the vagus nerve, we tend to have problems. Okay, so if we're thinking of our pyramid, we've identified our molecular mimicry and we've worked with healing up the blood-brain barrier. And why is that so important, that blood-brain barrier? Because we don't want these infections, which is step 3, to get across. All right. So we know that infections can play a big role in these neuroinflammatory cascades within the central nervous system. This is just a little depiction about various different infections and how they can affect different parts of the brain. So this is important to look at and be able to say, okay, what are we, is there a persistent infection or a reactivated infection? If there is there a break in the blood-brain barrier, and is it causing the cascade of inflammation and autoimmunity after it? So this, I believe, is even more important now that we are post-pandemic. These are just 3 studies. There are hundreds of them out there about reactivation of some of these viruses that tend to be very have a high affinity to your neurological tissue. So your herpes viruses, your Epstein-Barr viruses. And so we want to be able to pay attention to this, because maybe it's something that somebody had Epstein-Barr when they were in high school, but they got COVID and now they have all of these neurological issues. Is it long COVID, or is it Epstein-Barr that was reactivated that's flooding into the brain? We want to look at that. We want to pay attention. So you want to know which of these infections are really high and causing a chronic problem, because if we have an infectious insult that is not dealt with, then we can have a sequela of problems. So on our panel, you are going to see, these are going to be the infections that we are testing for. Some of them are just going to be singular as far as like the anti-HSV1. Others, like Epstein-Barr and cytomegalovirus, you're going to see them separated out into these recombinant antigens so that you can have a little bit more information. You get a great little lab comment that will tell you about some of the associations there, and we'll be testing them in the IgM and the IgG so that you can see where your patients, is this just a past exposure? Is this something that could be clinically relevant? I heard a description of this with one of our providers, and they said, although this is an IgG, when it's high, think about a tiger in a cage. If you have a tiger who you've been exposed to a tiger, the guard's been able to get him into a cage, right? And he only needs 1 guard, then maybe we're looking here at this moderate level. But if that tiger is really agitated or having, maybe it's a little bit hyper, maybe it needs some more guards there. So what happens in that situation is then if you get something like COVID, or you have high amounts of stress, you have a higher chance of that reactivating within the system. And so you do want to pay attention to these IgGs that are high, and maybe you're not giving them direct antiviral support, but you're giving them immune system support to take care of this kind of opportunistic infection as far as keeping it at bay and trying to stop it from reactivating. So this is a picture of just where the HSV1 is. This is going to be that general interpretation that I was just talking about. If you have a moderate IgG, then that's most likely indicative of just a past exposure. If you have a high IgG, it could be a past exposure, or it could be a chronic marker, but you need to clinically correlate that. If you have somebody who has a high IgG and they have it for HSV1, and then they have other markers on the neural zoomer that are associated with Alzheimer's, we might want to add in some herbal antiviral support or some immune system support to really help them with that issue and try and keep this IgG level and keep that tiger in its cage, okay? If we have an IgM, we're looking at a more current or active infection. So when we are identifying and addressing these triggers at the base of the pyramid, the neural zoomer does a great job of including those viral triggers, and it does include strep as well. So you get a lot of viruses and you get strep, but that's not all the triggers that can be triggering what's happening in the brain. And so there's other possible triggers for neurological antibodies, things like Lyme and co-infections. We also mentioned earlier about the anti-tubulin, the heavy metals, environmental toxins, mycotoxins, food zoomers, different types of foods have a lot of molecular mimicry. And then your leaky gut, leaky brain, that's going to have some connection there too with those blood-brain barrier markers. For the rest of today, we're going to primarily be talking about the Lyme and co-infections. Why do we talk about Lyme and co-infections so often when we talk about the neural zoomer plus, or even just neurological autoimmunity or inflammation in general? Well, Lyme tends to be, it's called the great imitator. And the neurological sequelae of chronic Lyme often causes some sort of encephalopathy, myopathy, peripheral neuropathy. This can be attributed to either persistent infections or this pathogen-induced autoimmunity. And you need to differentiate the two, right? So we need to run a Lyme test to figure out, are we just looking at a persistent infection, or are we also looking at autoimmune markers in the brain that are telling us that we're having this autoimmunity or this autoimmune sequela that's also happening? Because we don't want to just treat one, right? You don't want to just keep the patient in this kill protocol if you need to be dealing with the autoimmune over here as well. So when we look at the symptomatology of Lyme as the great imitator, it has a lot of those same symptoms that we talked about initially that are really good when you're thinking about the neural zoomer, okay? So things like fatigue or focusing or concentrating issues, memory issues, word finding issues, neck pain, sleep issues, headaches. So these tend to be problems that people come in with, and they may or may not say directly, well, I think I have Lyme. They may just say, well, I have a family member who has Alzheimer's and I'm having some memory issues, and what could it be? Well, you need to take that good history and figure out, is this a nice combination to come together for that patient? So staying on that same idea, what is the Lyme's connection to autoimmunity, right? Well, we have two studies that we can look at here. 10 to 20% of patients who are diagnosed and treated appropriately for Lyme disease go on to develop some sort of chronic autoimmune condition. Now, that doesn't necessarily mean a neurological condition, but a neurological autoimmune condition, but an autoimmune condition somewhere in the system, okay? So that's a pretty big population, 10 to 20% of patients, and these are patients who were treated. And I always think about, what about all the patients who weren't treated, right? And then if we're talking specifically about anti-neuronal antibodies, or what we're looking at as far as this neurological cascade, close to 60% of CDC positive patients who had prolonged antibiotic treatments are going to display this type of antibodies. That's a huge number. So it's not so much that we're just dealing with the infection, but we're also dealing with the aftermath. And being able to put these two tests together will be able to help us to determine how far down the track our patient is. Did they get onto the train because of Lyme? Is there a connection there that we need to make so that we know appropriately how to treat them? Okay. So some of the associations that we have, anti-tubulin is one of them. It falls under demyelinating agents. This one is strongly associated when patients come in and say that they have brain fog, or they feel tuned out, they have trouble concentrating, okay? These anti-tubulin autoantibodies are significantly elevated in Lyme disease compared to a control. So that's one that you really want to look for. Some others that you want to look for is the anti-neuron specific enolase, the anti-GM1, anti-NMDA, anti-dopamine 1 and anti-dopamine 2. I put some resources there so that you can read more about those. But those are some other markers that are going to have some associations with Lyme, which help us to figure out, when we see these markers, if we haven't tested for Lyme because it's not in our basic infection here, we need to test for it. And if we've done a Lyme test and we have a patient who has these types of symptoms, they have some sort of psychiatric symptoms or brain fog or neurological issues, we need to do the neural zoomer. So it's kind of a flip-flop. You could start here and go here, you could start here and go here. Really, the best is to do them together, because then you have the sample on the same day of their antibodies compared to their infections, and you get it all out of the way. Okay. So let's dive into a case, because although all of that information is helpful, sometimes going through the case is what turns the light bulb on. Okay, so we're going to do a clinical case workup with a Neural Zoomer Plus and a Tickborne. All right. Okay, so building a case, pretest probability. The best testing in the world still does not replace that you have to take a really good history, all right? Because so many times we are going to be going back to our history, correlating the markers that we're seeing with what's going on with the patient, and those are also going to be benchmarks to how is the patient improving, all right? So this is something that, yes, it's very important for Lyme, but I would say in general, do not neglect your history. So this is a 48-year-old female. She lives in Minnesota. She loves to be outdoors. She's had several tick bites in her lifetime, but no known erythema migrans rash, no acute Lyme disease. In the last 5 years, she's had brain fog, trouble concentrating, and chronic headaches. She's had some increased stress in her life in the last 6 to 12 months, and this has worsened her fatigue, her brain fog, the number of headaches. She is getting some minor cognitive decline and word finding issues. She's also had some increased anxiety and some OCD tendencies. She's had some weakness and loss of endurance in her muscles with routine activity, some blurry vision with prolonged reading or computer work, a slight tremor in her hands when she is fatigued. She has joint pain that tends to move around, migrating joint pain, and her symptoms tend to wax and wane every 4 to 6 weeks without trigger, although she never really feels well or like herself, right? She's like, I just don't feel like myself anymore. She does have a family history of dementia. She's worried about her brain health. And she's been dismissed from several providers, right? So this is pretty common. This patient probably walked into your office today, right? And she's been told by other providers, it's all in your head. You look so healthy. Well, you just need some more sleep. Well, you are getting older, right? Your labs are normal. Or one that I always heard was like, oh, but you have young kids, right? You just need more sleep. The kids will run you ragged. And you're like, no, those things are not, I know I don't feel like myself anymore. And so we have all of this information. What are we going to do next? Well, part of that pretest probability, I like to do some testing or some questionnaires, okay, especially when I'm thinking about Lyme testing. So I'm going to run an MSIDS questionnaire to see, do we have a high probability of tick-borne? Based on her history with the fact that she has migrating joint pain, and she lives in an endemic area and she has known tick bites, I already know that her MSID score is going to be high and she has a higher probability of tick-borne disease. But just from a, medical legal perspective, and you want to make sure that you have that in your chart, I would do an MSID. It's easy, have them fill it out. Have them do an MSQ, have them figure out what is going on with all of their symptoms. She had a 92, that's really high. This is a moderate to high body burden. And she had a lot of information in that neurological section. So I'm already also going to say I'm going to do her Neural Zoomer Plus. So then we're going to start with the tick-borne. You could start, you're going to run these tests concurrently. So you could start and look at the Neural Zoomer and compare it back to the tick-borne, or you could start with the tick-borne and compare it back. I just picked the tick-borne because those of you who know me know that this is where I spend a lot of my time. So let's look at this tick-borne test, okay? So as far as interpretation of the tick-borne test, you're going to get a summary. This is the same type of write-up that I had written for the viral infections, right? An IgG moderate means most likely we've had a past exposure. A high could be a past exposure or a chronic marker, but correlate clinically, you'll see that in a minute. And then an IgM, moderate or high, means that we have a current or active immune system response to that organism. Lyme is still going to be a clinical diagnosis. You're utilizing this test as how you build the framework. So that now you have a framework to make an educated clinical decision, because we had the pre-test probability and now we know what her exposures are, what her immune system is responding to, and then we pull that all together to make our clinical decision, okay? So if we're looking at her Borrelia burgdorferi page, this is where she has, obviously she's had exposure. She has persistent IgM activity. She did meet the alternative Lyme criteria for both IgM and IgG. So although she doesn't remember a more recent tick bite, she either has had just ongoing IgM activity, she still has that infection, or her immune system has not cleared it over or hasn't seroconverted it to the IgG. Another thing that is very important to look at is this band 31. Many Lyme literate providers are going to call band 31 your bingo band. Okay, so like if you have a band 31, it is Lyme. Some of them say even without the criteria, you have to make that decision as you see fit as a provider. But the clinical correlation or clinical consideration I want to give you today with band 31 is how it relates to the autoimmunity within the body. So look at this study. So we have that band 31 particularly has molecular mimicry to initiate autoimmunity. If you are running a Tickborne test and you see somebody who has a band 31, you need to check them for autoimmunity. These people are going to be more likely to have autoimmunity because of the molecular mimicry than maybe somebody else who doesn't have a band 31 but still is positive for Lyme. So not everybody who has Lyme has the autoimmune sequela, but if you see a band 31, you need to be checking for it, okay? So as far as this patient's co-infections, she's had some evidence of exposure of Babesia, but it is a low IgG. Still going to clinically correlate that just to be on the safe side, but I'm not thinking that this is an infection that I need to deal with. And then her Bartonella is just over high. It is coded as red, and so we really do want to clinically correlate that. What does that mean when I say clinically correlate it? These are some symptom profiles for these two particular co-infections. And many of the co-infections, whether we're talking about Babesia or Bartonella, or Anaplasma or Rickettsia, will have this kind of symptom cluster. The patient doesn't need to have all of them, but if they have several of them and they have a high IgG, that may be more of a chronic marker and something that you need to bring into your treatment plan. Okay, so this patient, looking at that whole history that we had, the things that stood out to me with that higher level of Bartonella is that she was reporting some tremors in her hands up when she was fatigued, she was having some increased anxiety, and she was having some OCD. So those are things that we might need to make a clinical decision that we're going to also be giving her a level of treatment for her Bartonella. Okay. So what is our conclusion with our Tickborne test before we move on to our neural zoomer summary, and then we pull it all together for you? So as far as our Borrelia species, she was positive for Lyme. She had the alternative criteria. Oh, this is also supposed to say IgM. She had both IgG and IgM. She also had a positive IgM serology for Borrelia fusarrii. We talked about just now about her Bartonella and her Babesia. Her Babesia, no evidence of an active infection after clinical correlation. It was a low IgG, so we're really going to put that on the back burner. We may monitor her symptoms throughout treatment and look at that. How is that affecting her brain? Okay, so here is her neural zoomer. We need to now think about that pyramid. So think about our pyramid here, right? And our blood-brain barrier. And we need to determine what of these markers have associations with things we can control, associations with infections that we know, to be able to give this patient some good, solid treatment plan to help correct her course. All right. So what do we know? We want to think about this pyramid, right? It's the same pyramid that I put up at the beginning. You start at the bottom. We already know her Lyme. We just talked about it. So you could even write it in right here at the bottom of your pyramid. And sometimes I do that with patients. I'll print off this summary page. And if I've done other testing like a Lyme test and I have those in a, in a moderate or in a positive, I add them right onto the summary page because we know that they're contributing to those autoantibodies as well. So what are her other infections that she has? Well, she had an over 30 IgG for EBNA1 for Epstein-Barr. Now, an EBNA1 IgG with none of these other markers, recombinant antigens, usually just means that's a past exposure. And that is true. However, remember, her tiger in the cage probably has quite a few guards around it. So I would want to make sure that we are supporting her immune system so she doesn't have any reactivation. Same with both this HHV6 and HHV7. They're both in the high level. So they are past exposures. You could add in maybe some herbal antiviral support, but at the very least, you want to make sure that she has her nutrients that are going to be supporting her immune system to be able to keep those things at bay. Then as far as what do we know? Think about the base of her pyramid, right? So of these markers, what types of molecular mimicry do we know of? Well, based on some of the studies that I showed you before, this anti-neuron specific enolase, this has an association with Lyme, right? It often can be high in your Lyme patient. So we are looking and saying, okay, this one is in the category of optical and autonomic nervous system. It possibly could be correlated to her blurry vision. The anti-dopamine, this has to do with a dopaminergic dysfunction. This could have to do with some of her hand tremors, right? This also could have to do, when we look at anti-dopamine 1, that's anti-dopamine receptor 1, dopamine receptor 1, that has to do more with like the neuropsychiatric symptoms, so things like the anxiety or OCD, but it also could be associated with brain fog and headaches. This one is one of the markers that we talked about before that has an association with Lyme. So you could see where if I got this test without her Lyme test and her other infections, let me just go back here for a second, we're all living in the IgG and didn't have any real direct correlations, I might say, well, what are some of my action items? But doing these tests together helps to give me that information. So we have some associations with Lyme here and associations with Lyme here. The anti-acetyl choline receptor, this one has an association with myasthenia gravis, or this autoimmune connection at the neuromuscular junctions. Okay, this could possibly be correlated with the fatiguing muscles when she has routine activity. There's not going to be a lot of direct molecular mimicry with this particular marker, but this falls into the fact that it's at the maybe more the top of the pyramid because it has that autoimmune connection with the neuromuscular junction. So if we can really work on the foundational part of the pyramid, we can make some good strides to fixing some of her symptoms at the top. And then her anti-glucose regulated protein 78. So say that 3 times fast. I know that was a mouthful, and we don't necessarily need to know all the details, except for we know that there's a molecular mimicry association with this, with anti-aquaporin 4 antibodies. And this is part of the blood-brain barrier. So one action item for her is going to be that we want to remove any aquaporins that could be damaging her blood-brain barrier. Now you could run an lectin zoomer to test more specifically on her aquaporins. What if she continues to eat corn or soy and those types of things are causing problems for her, and every time she eats them and she's getting destruction of the blood-brain barrier, we're going to have a hard time calming everything down. So what does this look like? Well, this looks like this. All right, so here's our conclusion. We're going to pull all of our pieces together. So our patient, she has a known association with Lyme with an anti-neuron specific enolase. We know that she's going to fall into that 60% of patients who's going to get some neurological autoantibody activity after a Lyme infection. We also know she still has some infections. We've got Lyme we need to treat and some Bartonella, and we have some viral infections or opportunistic infections that we need to address. These things need to happen concurrently while we are dealing with the blood-brain barrier, because you don't want to, you've got to heal up the blood-brain barrier so the brain now is still sitting back at that seat of privilege, and we're not having this flood of autoantibodies or infections kind of coming across the barrier. So you want to be doing kind of all three of these things. When I said like step 1, step 2, step 3, you don't necessarily do step 1 and then wait and then go to step 2 and then wait and then go to step 3 and then wait. You want to do them kind of collectively together. So you're going to heal her blood-brain barrier by removing her aquaporins that she tested positive for, or at least putting her on a diet that is low in aquaporins. You're going to be doing all those other blood-brain barrier treatment considerations that we talked about. And then when you do that, you think about focusing here. What that's going to do is it's going to calm down the inflammation, because if we deal with the Lyme, that's going to calm down why her brain has inflammation, right? We figured out the mechanism. We knew why she got on the train, so now we can slow down her train. And then same with the autoimmune cascade. Do we need to say, oh, you've got myasthenia gravis and, nothing we can do? No, it's not diagnostic. We're not saying you have myasthenia gravis, but you have a clinical presentation and a marker towards that. We know it's part of this autoimmune cascade. And so we also know that we have all of these action items down here so that we can start to pivot away from that autoimmune cascade. So don't jump in at the top of the pyramid. Start at the bottom, assess and treat your infections, heal your blood-brain barrier, and then know that the pyramid is going to build up on top. Okay, so thank you everyone for spending the evening with me. I hope that you learned something. I will open it up for a little bit of questions.
Okay. One question that came in during the presentation was in regards to follow-up or repeat neural zoomer. Have you ever seen a repeat neural zoomer, and what sort of results can you expect when someone does a protocol?
Very good. That's a great question. So I recommend doing repeat neural zoomers at least 6 months, maybe out to 8 months. Because what we're going to anticipate seeing is that we're going to see kind of, if something was in an IgM, you're going to see a transition over into IgG. And then if you have an IgG, you're going to start to see those decrease. But remember that you're seeing, you normally will see these IgMs maybe around for about 3 months, and then the IgGs for like 6 to 9 months, but that's 6 to 9 months after the last trigger, right? So if all of a sudden, if it's self and they're continuing either to be exposed or they're continuing to eat the food. So do understand that you've got to address all of these reasons to why the antibodies are there. If you go through a protocol, giving yourself something like 6 to 8 months to see that clearance. And I have seen some really phenomenal repeat neural zoomers where sometimes, like one of them I saw, there was like almost more antibodies over on the positive side than on that negative side. And you start to see them transition over as the barrier heals up and the immune system calms down.
Awesome. Thanks for that. Well, I'm not seeing any other questions at this time. You did a great job. Answered everyone's questions before it even ended.
There we go. There we go. Well, thank you so much for joining, everybody. I hope you enjoy the rest of your evening and your holiday next week. And we'll talk to you soon.